All right, so this chapter is about how to use all the information that we have from this course. And the course is about exercise physiology. So therefore, the course is about how the human body is going to change because of exercise. You have anatomy and you have physiology. Anatomy is like the name of the thing, and physiology is how that thing works. So exercise is going to change the, I guess, anatomy. It's going to give you, more type 2 muscle fibers, increase heart size, all that stuff. And what that's going to do is change how it works within the multiple systems of the body, the neurological system, cardiovascular system. How does exercise change? It's not going to change the anatomy, I guess. I mean, in some instances, it may, change the anatomy. Does exercise? It changes aspects of the anatomy, like, for instance, the density of bone. Why is this work happening? It will change. There we go. The density of the bone, I guess. Maybe that's changing the anatomy. And I guess it's changing. Anyway, we don't have to get into that. But it's also considering how to use exercise as a prescription. Now, what does that mean? What does use exercise as a prescription? Well, my mom is a pharmacist, and my mom prescribes medication. So I called my mom a long time ago and I was like, wow, does that mean that if we're supposed to use exercise as a prescription, does that mean that the workout industry is in direct contrast with or competition with the pharmaceutical industry, right? This is the workout world, and this is medication. So isn't this kind of like an irony here? And she said no, because the first thing that every healthcare provider or person who could potentially prescribe medication is told is they want to change lifestyle before they start doing medication or pharmacological or surgical procedures. So it's always beneficial to change lifestyle before given medication, and you can change the lifestyle through this awesome thing that we do called exercise. And not only that, but like probably I think that this word goes hand in hand with exercise, nutrition. And some of the nutrition that we suggest is going to be for the normal population, but other nutrition and exercise prescriptions will be based on the health and fitness, wellness of the entire population. So, how do we use exercise as a prescription or a drug or some type of intervention for things like cardiovascular disease? All right. Maybe what I'll do is I'll ask Tatiana, what other health morbidities do you think that we could use exercise to help mitigate mortality and morbidity rates?
Would it just be like aging in general?
Well, so you bring up an interesting point. We're going to get to the risk factors associated with cardiovascular disease. And one of them indeed is age. But let's say, for instance, we want to use exercise as a prescription to heal people of something, because that's what you give medication for. What are the morbidities, which Tatiana means a disease? What are the diseases that are prevalent in today's society that you think that we could maybe positively impact with exercise?
Muscular diseases or skeletal diseases?
Okay, so that's probably pretty interesting. Let's write that down. So let's say a skeletal injury. Now, how about if I just wrote like osteoporosis? All right, because that indeed is an injury, and I'll just say osteo problems. Osteo is bone, and then bone problems. So if I do a lifetime of physical activity, my bones will be more dense, less brittle, stronger, and stiffer. So I agree with you. Tatiana, something else here, something else down here. Cardiovascular disease, osteo, um, bone issues, and what's something else here, you think?
Pulmonary issues.
Oh, definitely COPD. All right. And just so we don't have to belabor the point and keep you on the spot for too long, how about type 2 diabetes and cancer and blah, 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 and all the rest of these things. So, how do we use exercise to address each of these major health concerns? And when we're talking about major concerns, when we watch and not only that, but I mean, and this is kind of like if I had like a stylus that I could write and make this faster and easier, I would write obesity, hypertension, I would write dyslipidemia, I would write all of these other things here. But not only do we know, like, this is caused cardiovascular disease is something very, very different than bone disease, osteoporosis, which is very different than lung disease, which is very different than insulin sensitivity issues. So what you have to fix, or the problem in each of these cases, is very different. Therefore, usually the prescription is going to be different. Let's say you had cardiovascular disease, you would give, I believe, Lipitor. If you had osteoporosis, you would give probably a calcium supplement. If you had COPD, you would give albuterol or Ventolin. If you had type 2 diabetes, you would give a different medication, a different medication. So for each one of these morbidities, you might have to give a different exercise or a different frequency or intensity or time or mode or type or heart rate percentage in order to achieve beneficial results for each one of these. For instance, cardiovascular disease. The research suggests that you should exercise at moderate intensity, at least exercise, to positively impact cardiovascular disease. Moderate intensity, at least. Moderate to high intensity exercise. What that does is it forces the heart to work harder, strengthens the heart, pushes more blood more forcefully through your arteries, which is going to work to expand the arteries. But if I have type 2 diabetes and I don't exercise at all and I'm obese, then I don't have to work at necessarily moderate to high intensity. Any type of physical activity for somebody who doesn't do anything at all is beneficial. So in that case, the intensity or the frequency of exercise would be different depending upon each of these risk factors. So now we have to understand the risk factors and be able to apply the right exercise in place of a prescription drug so that we can address lifestyle rather than like pharmacological intervention. So now we're going to start using exercise and nutrition as a first line of defense to help reduce all of these particular morbidities and improve the health and fitness profile and therefore the wellness of our community. That's pretty much what we're trying to do now. All right, so let's get into the chapter, and what we'll end up talking about is the risk factors that make it more possible or increase the potential of you getting cardiovascular disease. So let's erase or clear all this stuff and let's get into it. Oh, mouse. So the exercise talk, the chapter talks about the health benefits of exercise. At this stage of the game, I don't really want to belabor all this. I think that we all understand what the benefits of exercise are in terms of neurological function, cardiovascular function, cardiorespiratory function, bone strength, everything. But we can't just allow anybody, if we're, say, for instance, a workout um, facility, we can't just allow anybody to exercise when they come in. Some people are not going to be healthy. And if they're not healthy, they're going to need medical clearance. So how do we assess the risk of an individual to see whether or not they need medical clearance or do not need medical clearance? Well, we've already taken a look at one way. One way is that PAR-Q, the physical activity readiness, and then questionnaire. We took a look at that at one of the labs that we did a couple of days ago. So we got to make sure that people have a PAR-Q, a medical history questionnaire, a lifestyle evaluation, right? If they answer yes to any of these, they got to go get a PAR-Med-X and blah, blah, blah. But we also have to be able to take a look at risk factors for cardiovascular disease, because if they have a heart attack while they're doing the activity, that's not a good thing. So we have to determine whether or not an individual is healthy enough at the time to do exercise with or without a doctor present. Then once they learn how to, once we understand the health and wellness of the participant, we can provide the right medical coverage so that we can do an exercise test. And you could do a submax exercise test. You could do a maximal stress test. And then what you'll do is understand how that individual responds to physical activity. And then what you'll be able to do is provide the correct exercise to address the appropriate. One second. I thought I was frozen for a second. You'll be able to provide the correct mode and type of exercise to address the particular risk factor that you're trying to reduce. All right, so let's keep moving on. Yeah, the health benefits of exercise have been researched throughout the last 100 years, and exercise is beneficial. All right, but I don't want to get belabored into all of these, the statistics. The big statistics that we want to talk about is how exercise is not something that everybody does every day. For instance, just like to make an admission, I don't really exercise that much. I coach gymnastics, so I go to the gym and I spot kids all night. I do that all night, but I don't really go out and run. I don't lift weights and things. All right, the problem with exercise in this country is that people don't do it. We all understand that it's beneficial. We all understand all of these health benefits. I don't think at this stage of the game, you and I need to go through all of this research proving why it's good for us. It's good for us. We all know it. But the truth is, if you give people a questionnaire, you give the population questionnaires and you ask them about what they do in regards to their exercise, you'll see that less than 50% of the country does daily physical activity. Even though we know it's good for us, we don't really do it. And There's things that you've been taught, I think, throughout the course of your, collegiate career, and maybe this course, that other people just don't know. Like, other people don't know the impact that sugar has on your waistline. Other people don't understand the impact that insulin has on the storage of body fat. So people, not only that, but the knowledge that people have, and this is what I try very hard to do in my courses, is the knowledge that people have is just based on the common day knowledge that, you know, I guess that we're taught, that doesn't really necessarily hold true all the time. For instance, the brain is like a computer, the eye is like a camera, and blah, blah, blah. So the knowledge that we're given is sometimes limited, and sometimes people just don't have the actual knowledge to be able to apply things. Like, if we're talking about computer science, I don't have the knowledge to be able to apply anything. I can't, I really don't, I really can't help you. But if we're talking about exercise physiology, then I have that knowledge. So I can apply that in my own life. I can apply what I know about nutrition in my own life. I can apply what I know about behavior change to try to change my own patterns. But, if you don't know, it can't hurt you. So you have to have knowledge and be able to apply the knowledge. So in our environment, I mean, I've never seen advertisement for exercise on Instagram and Facebook. You'll see a lot more of it, but on the television, I've never seen it. So if people don't know about it and it doesn't show a priority to the population, then unfortunately it's not. And the priority is not exercise, because if you exercise, you don't make the dollars. You know, very few people are going to make money exercising. They're going to save money with health, but the priority is rent, health insurance, all that stuff. I got to work. I got to work. I got to make money, because rent is due at the end of the month. And in about 3 years, you guys are going to have to pay for your own health insurance and all that stuff. And all of a sudden, the priority for me is not exercise, it's work. But then my health declines, and then it's just a never ending circle. So exercise doesn't have to be this go to the gym and lift heavy weights and do all that stuff. It doesn't have to be like that. All right. It can be as little as just 30 minutes a day, walk kind of 3.5 miles an hour, or do 15 minutes of running. That's it. 30 minutes. If you could tell everybody, just go walk 30 minutes a day, that'll increase their health benefits statistically, and it'll reduce the potential risk for cardiovascular disease, because now you're doing physical activity. All right. So before people do physical activity, they're going to need to get medical clearance. The medical clearance is based on risk. So how do we establish an individual's risk? Well, we take a look at things like blood pressure, percent body fat, heart rate, blood pressure. We do a medical evaluation. All right. That medical evaluation is going to get the person to say, man, I have high blood pressure. High blood pressure. What should I do about it? What should I do about the fact that I'm 29% body fat? What should I do about high cholesterol? Well, I got to do something about it. Now, the something about it is either medication or exercise. So what are you going to do? Well, you're going to have to figure out whether or not you're at low, moderate, or high risk. And low risk means that you do not need a doctor in order to do physical activity. Moderate risk, though, if I have two or more risk factors. A risk factor is a thing that increases the risk for something. So these are not good things. Risk factors are no bueno. You do not want to have a risk factor that increases the risk for cardiovascular disease or pulmonary disease or metabolic disease, which is the combination of obesity, hypertension, and cardiovascular disease. All right. And type 2 diabetes, rather. So if you do not have any signs or symptoms of each one of these diseases, but you have risk factors, then you would be at moderate risk. If I have signs or symptoms of disease, or if I have more than 2 risk factors, then I'm at high risk. And if I'm at high risk, I cannot do exercise unless I have clearance by a medical professional. Same thing with moderate risk. Low risk, good to go. So let's show you the risk factors for cardiovascular disease. Most likely what we're going to do is just go over this for the rest of our class today, because this is really the most important thing. How do I know how much risk I'm at? And now these are risk factors for coronary artery disease. Coronary artery disease is the increase in plaque in your blood vessels, in your arteries, so that your arteries start to get like caked with plaque, and the lumen, which is the space where the blood flows, starts to get occluded. And then a piece of this little plaque can break off, become a blood clot, and jam this artery. Or just the blood flow through this artery is so occluded that you start to lose oxygen to the heart. And because the arteries are diseased, all right, it's going to increase the risk for further cardiovascular disease events like myocardial infarctions, which is heart attacks, or strokes, which is burst blood vessels in the brain, or dislodging of these little plaques into the bloodstream. They travel to the brain and lodge in a blood vessel in the brain and block the blood from going to the brain. And then you have a stroke or a reduction of blood flow to the brain for that reason. So here are the risk factors for coronary artery disease. So let's count the number of risk factors that I have, because I guess I feel somewhat healthy, right? I could be much healthier if I exercised, but I'm trying to make good changes in my life that are making me healthier. But let's take a look. So the first risk factor is something that is non-modifiable. There is nothing that we can do about our age. It's only going to get higher and higher. And I can't do anything to reverse that. So at some point, everybody is going to have a positive risk factor. You guys don't have much to worry about, but I'm 44 years old and my birthday's in November. So I think that, like, for all intents and purposes, there's nothing I can do. All right, now I could say, well, I'm only 44 and a half years old, so I don't have the risk factor. Okay, great. But let's just round up. So I have one risk factor, dang it. All right, now you'll notice that males who are greater than 45 years old have a positive risk factor for coronary artery disease, and females who are greater than 55 years of age. So it seems as though not only age, but gender seems to be another confounding factor. But since it's not listed as an official risk factor, then I won't mark it here, but let's just make a note of it up here. All right, let's just make a note of it down here. All right, now a positive risk factor, even though the word positive is affirmational, you do not want a positive risk factor. A positive risk factor increases risk. A negative risk factor is a good thing. All right. So I'll show you what a negative risk factor is first, but let's just discuss these. So for me, I have one positive risk factor. If you look back over here, low risk is if I have less than 2, because 2 plus would be moderate risk. So a low risk is if I have, by that rationale, 1 risk factor. And if I have only 1 risk factor, I'm at low risk. I'm a healthy individual, and I do not need any further medical evaluation to do exercise. But if I have 2 risk factors, I'm at moderate risk. If I have no signs or symptoms of cardiovascular disease, it's recommended that I get some medical evaluation prior to doing exercise, but it's not mandatory in some instances, and we'll show you why. But if I have more than 2 and I have signs or symptoms, then I'm at high risk. So let's go back up here. So men, 45 years of age. There we go. That a little bit bigger and move it down. All right. So the next one is, oh, that's where it was. Positive risk factors. All right. So unfortunately, I have 1 risk factor. Next one, family history. Now, if you have a member of your family who has had cardiovascular disease, or they've had a myocardial infarction. Myocardial infarction is another word for a heart attack. Myo is the muscle of the heart. An infarction, I mean, I don't know the technical definition of infarction, but it's when the muscle of your heart doesn't get blood and doesn't have enough oxygen for the tissue to stay alive, really, and it stops functioning. So that's a heart attack. Coronary revascularization, right? Coronary is heart, and revascularization is if somebody's had like a bypass, right? They have a revascularization of their coronary muscle. Sudden death before 55 years of age in a father, or other male first degree relative, or before 65 in a mother. So my dad had a couple of heart attacks before he passed away. I don't think he was before 65 years of age. So let's just say I don't have any idea of any other issues in my family that would count towards this family history risk factor. So I don't think that I have that risk factor, but my dad was pretty unhealthy. So maybe what we could do, I mean, he had a lung transplant, he had, major system failure, blah, blah, blah. We don't want to get into that, but I don't technically qualify for family history as a risk factor, but I'll just put a little note down here. Cigarette smoking. I do not smoke cigarettes. But let's say I did. Well, that would be a risk factor. But if I quit within 6 months, that is no longer a risk factor for cigarette smoking. But cigarette smoking is a risk factor for coronary artery disease. So I do not have that risk factor. Hypertension. Systolic blood pressure. We talked about systolic blood pressure. Systolic blood pressure is when the heart contracts. So when the heart is beating in, boom, like this, the muscle is contracting. When that happens, it increases the pressure in the heart, and it takes the blood and pushes it out of the heart. that means the blood is going to push through the aorta, and it's going to push the blood vessels open because the blood is creating pressure on the outside of the vessels. Now, if the systolic blood pressure is higher than 140 millimeters of mercury, systolic blood pressure is when you reduce the little needle, you reduce it, you're not going to hear anything, not going to hear anything, not going to hear anything. Eventually, boom, boom, you're going to hear your first beat, boom, that's a systolic. Then you're going to hear the heartbeat, hear the heartbeat, hear the heartbeat, hear the heartbeat, and eventually you're not going to hear the heartbeat, boom, that's diastolic. Usually the systolic is going to be about 120. So if it's more than 140, that is an indicator of high blood pressure. Or if the diastolic blood pressure is greater than 90. So usually the systolic blood pressure should be about 120, and the diastolic blood pressure should be about 80. Now there's a little wiggle room, but if the systolic blood pressure is 140 or the diastolic blood pressure is 90, all right, that is an indicator of hypertension, too much tension on the blood vessel walls. Because of that, the blood vessel walls become injured and they become like covered with this arterial sclerotic plaque, which causes coronary artery disease. Something that exacerbates that is the amount of fats and cholesterol and oils and bad fats in your diet. Now, low density lipoproteins, this is called DIS. DIS is bad, lipid is fat, and emia is blood. So bad fats in the blood. Low density lipoprotein, these are cholesterols. They're molecules that are lipos, which is a fat, and a protein. They're fats and proteins. They're kind of like big molecules that float through your blood when you eat a lot of fats. And some of these cholesterols are good and some of them are bad. Low density lipoproteins are bad. They're very small and they have a low density, so they're heavier. And what they do is they get lodged. This is a blood vessel here. They get lodged underneath the inner cell walls of the blood vessels. They get lodged underneath. And what they do is they start to push the blood vessel cells away from the cell wall. And then the blood vessels become what like the body thinks is injured. So it sends like scar tissue to try to cover up the low density lipoproteins. And that scar tissue is plaque. And it closes down and jams the blood vessels so blood can't get through. The low density lipoprotein is such a low density and they're so small that they can actually fit underneath the cells of your vessels. You don't want a lot of them. So if you have one second, I'm just going to erase this just to make it a little bit clearer. If you have a lot of them, it's not a good thing. So if you have more than 130, just remember that number, 130 of low density lipoprotein, it's not good. It's not good. You want to have low. You want to have a low number. And you remember that because low density lipoproteins, you want a low number. Low number for low density. And the number that you'll have to remember if you're like going to take a test is less than 130 milligrams per deciliter. Now, high density lipoprotein is different. They have a high density so that they float more and they're bigger. So the high density lipoproteins come through the blood vessels and they actually dislodge the low density lipoproteins. So high density lipoproteins are good. Low density lipoproteins are bad. You want a high amount of high density lipoproteins, and you want a low amount of low density lipoproteins. So the number that you want to like remember with high density lipoproteins is less than 40 milligrams per deciliter. So 130 and 140. Now you'll notice that there is a negative risk factor. A negative risk factor. Negative risk factor actually reduces the risk. So this is a good thing. And you'll notice it says high serum HDL. So if I have a high amount of HDL, high density lipoprotein, and what does that mean? If my value is higher than 60, that's good. That becomes a negative risk factor. So I'd add up all of the risk factors that I have, and I would subtract one. That's what a negative risk factor is. So high density lipoprotein is good. All right, so let's try to see if I can fix this. There we go. So I want to have a good amount of high density lipoprotein, and I can erase this. So I want high density lipoprotein values that are higher. So you'll see there's a less than sign. If my HDL is less than 40 milligrams per deciliter, that is a positive risk factor, not a good thing. So I want low value of low density lipoprotein and a high value of high density lipoprotein. And if you add the value of your LDL with your HDL, you should have a value that is less than 200 milligrams per deciliter. Now, if it's greater than, there's a greater than sign. If it's greater than 200 milligrams per deciliter, it's a positive risk factor. So just be careful how you interpret the greater than and less than signs. Sometimes it can be a little bit kind of confusing. Now, I do not smoke cigarettes. When I drank, I used to have high blood pressure, but I don't have that anymore. But I don't, and I haven't checked my blood levels. I have no idea. So unless I go to the doctor, I have to consider that a potential risk factor because I don't really have the information. All right. Now, in regards to diabetes, when you're fasting, which means you have no food in your body, you fasted for 24 hours. You take a look at the amount of sugar in your blood. And if I'm fasting and I don't have any carbs in my diet, I shouldn't have too much sugar in my blood. But if I do, if I have more than 100 milligrams per deciliter, all right, but less than 126, then I'm at risk of prediabetes. And prediabetes, not just diabetes, but prediabetes is a risk factor. If I have more than 126 milligrams per deciliter, I no longer have prediabetes. I have type 2 diabetes. So how do you figure out what your fasting blood glucose is? Well, you would do one of those little finger prick measurements, and you would look at a glucose monitor. I do not have diabetes, although at the same time, I haven't been checked if I do have diabetes in some time, but I do not believe I do, so I'm not going to add this to there. Obesity. Obesity is a body mass index, but remember, body mass index, kilograms divided by meters squared. So this is weight divided by height squared. But that weight doesn't indicate whether or not the weight is muscle mass or fat-free mass. Well, muscle mass or fat mass, rather. So this is very misleading here. And if you're going to do body mass index, you would want to also do something like bioelectrical impedance, DEXA, the hydrostatic weighing, something to validate this number. But body mass index is a statistical measurement that has been statistically correlated with obesity. So it's used, but be careful with this. Or a waist ratio, waist measurement of more than 120 centimeters or 40 inches for men. I'm 32, so I'm good here. So I do not have an obesity risk factor. Sedentary lifestyle. People who do not participate in 30 minutes of moderate intensity, moderate intensity is 40 to 60% of VO2. All right, on 3 days a week. I don't do that. Now, what is moderate intensity? Moderate intensity is 3.5 milliliters per kilogram per minute. 1 second. Moderate intensity is not that. Intensity, though, intensity of your exercise is based on this value here. Now, each individual, depending upon how heavy they are, let's see if I can expand this. All right, maybe I can just get rid of some of this stuff and make it a little bit cleaner and just talk about this negative risk factor stuff. It's 9:34. All right, I'm gonna go for about 10 minutes. We'll start the IRAT, GRAT stuff at about 9:40, but let me just go for a couple more minutes. So this value here, 3.5 milliliters per kilogram per minute. This is the amount of oxygen that somebody is going to use at rest, VO2 at rest. An individual, on average, uses 3.5 milliliters, depending upon their body weight, every minute. So if I weigh 60 kilograms, I'm going to be using about 1,800 milliliters or 180 milliliters, which is a little bit more than a liter. All right, per kilogram. So 180 milliliters per minute. Correct. So what we can suggest is that they do exercise for 30 minutes at moderate intensity. Well, moderate intensity means what you want to do is exercise at 40 to 60% of your VO2 max reserve, their VO2 reserve. But you can also measure that in what's called their METs, metabolic equivalence. Now, one metabolic equivalent, one MET, is equal to 3.5 milliliters per kilogram per minute. And the way that you can like think of a MET is it's the amount of oxygen, VO2, that they use at rest divided by the VO2 that they're using now. And I'm also going to go like this. And I don't do this often, but sometimes I make mistakes. That's better. All right, so a metabolic equivalent is equal to this right here. All right, it's a ratio, a ratio. So if the top is the same as the bottom, then the ratio is going to come out to 1. So one metabolic equivalent is equal to the amount of oxygen that I'm spending now divided by the amount of oxygen that I spend at rest. Now, as I teach you, I'm sitting, I'm resting. So now the amount of oxygen that I'm spending is the same as the amount of oxygen that I would spend at rest. So my resting metabolic rate would be 1. The same amount of oxygen that I'm doing now divided by the same amount of oxygen that I would spend when I'm resting. Now, if I get up and start walking around, then if I start running around, I'm going to start using more oxygen. So this value is going to go higher and higher and higher and higher. 40 to 60% of my VO2 reserve is between 3 and 6 METs. So if I am doing now what if I'm doing now 3 times the amount of, I guess, effort, so I'm spending 3 times the amount of oxygen now than I would have at rest, then I'm spending 3 METs worth of intensity or worth of exercise intensity here. If I'm spending 6 times the amount of oxygen now compared to when I'm resting, that would be like the borderline of moderate to high intensity exercise. So this range right here, 3 to 6 times the amount of oxygen, is the kind of range for moderate intensity exercise. So in order for an individual not to be sedentary, they need to do at least 30 minutes of 3 to 6 METs 3 days of the week consistently. It says for 3 months or more. I don't do that. I have 3 risk factors for coronary artery disease, and I really can't do anything about one of them. And I could change and modify 2 of these so that I could go back to low risk. Now that I've changed a lot of these things about my, lifestyle, maybe I can start to think about a little bit more physical activity and then better my own risk for getting coronary artery disease and by using exercise to do so. All right, so let's go back. We'll finish up this part real quick, and then we'll go to do our IRAT, GRAT. And we just want to be able to figure out whether or not people are at low risk, moderate risk, or high risk of doing exercise before they do exercise. And this is kind of a flow chart that you could use to figure out what level of risk they're at. And then we'll be done after this. So what you want to do is I gave you a PAR-Q, a physical readiness questionnaire, also gave you a medical history questionnaire. I gave you a lifestyle evaluation questionnaire, and you're going to review their health history. Find out whether or not they have any signs or symptoms of coronary artery disease or risk factors. That's what we got to do. That's the goal. So you review it. And if you review it and they have any known cardiovascular, pulmonary, or metabolic disease, then they're in this yes route. If they have any known diseases, like if they've had any cardiac disease or blood vessel problems, or if they'd had any like brain, cerebro is brain vascular blood vessel problems, or if they have COPD or asthma, or if they have cystic fibrosis or diabetes, or they have any other kind of renal liver disease. If they have a known disease, yes, If yes, high risk, go see a doctor before you can do exercise. If they do not have any known cardiovascular, heart, or metabolic disease, then do they have any signs or symptoms? Are they shortness of breath? Do they have dizziness? Do they have ankle swelling? Do they have high blood pressure, low blood pressure? Do they have fainting with walking? Do they have heart murmurs? Do they have any issues at all? If they have any issues, any signs or symptoms, if yes, high risk, boom. If they don't have any major signs or symptoms, then you look at the number of cardiovascular risk factors, the ones that we just talked about. And I have 3 of them. If I am greater than 2, moderate risk, boom. If I have less than 2, low risk. Less than 2 is 1. So if I have 1, I'm low risk. If I have 2 or more, I'm at moderate risk. But some will say if you have 3 or more, you're automatically high risk. So if I have any signs or symptoms, if I have any known disease, or if I have 3 or more of these cardiovascular coronary artery disease risk factors, I'm immediately high risk and need to have an exercise assessment performed by clearance by a medical professional and an exercise assessment done before I participate in physical activity. If I'm at moderate risk, I just need a doctor's clearance if I'm going to do a maximal exercise, like the Bruce treadmill test at 100% effort.